In this module, I am going to discuss about an important group of condition affecting the neonate, and that is infections in a newborn baby. When we talk about infections in a newborn, we divide them into superficial infection and systemic infection. Systemic infection is what we call it as sepsis. First, I will discuss about the superficial infections part. Okay. A typical example of superficial infection is something called as omphalitis. What is the meaning of this omphalitis? Omphalitis is infection of the umbilical cord itself. This condition usually presents as a redness around the umbilicus or induration around the umbilicus or a pus discharge from the umbilicus region. This is how this condition usually presents with. Okay, right. Even though this is a superficial infection, this has got a potential to spread into a systemic infection. That is why management of this condition depends upon how far the infection has spread. For example, if the size of the induration or the size of the redness is less than 1 centimeter, okay, and if the baby has no evidence of sepsis meaning systemic infection, then you can manage with topical treatment only. What is the topical treatment which is recommended? It is 0.5% gentian violet application 4 times a day. This is what is the treatment recommended if it is a localized infection like less than 1 centimeter in size. Okay. Suppose the infection is more widespread. For example, the induration or redness is more than 1 centimeter and or the child is having features of sepsis. Then you have to treat like sepsis with systemic antibiotics. Typically, an intravenous antibiotic is given. Details about systemic antibiotic treatment for sepsis will be covered in the later part of discussion in this module. So that is how you manage a case of omphalitis in neonate. The next superficial infection which I am going to discuss about is called as oral thrush, which we all know is caused by candida. Okay. Sometimes it is difficult to distinguish oral thrush, which appears as a white colored lesion, from other lesions. So what is the pointer that the white lesion in the mouth of a newborn baby is actually oral thrush? There are two things. First, this oral thrush is difficult to wipe off. Second thing, if you try to remove this oral thrush forcefully, after removal, it will leave some hemorrhagic spots. After you remove or wipe off those lesions. This is how we typically say that the white lesion is actually a oral thrush. Okay. So management of oral thrush is basically topical application only. What you do, you apply topical nystatin or topical application of clotrimazole for 4 times a day. This has to be continued till all the lesions are resolved. Okay, that is what is the management of oral thrush. Now there is one more superficial infection also which you should know about. That is about conjunctivitis in a newborn. Please remember how the baby contracts the infection. It is acquired while the baby is passing through the infected birth canal of the mother at the time of delivery. Okay, and there are 2 important organisms implicated in the causation of conjunctivitis in a newborn. They are, one is gonococci and the other one is chlamydia. Gonococci we all know is caused by Neisseria gonorrhoeae and chlamydia is caused by Chlamydia trachomatis. Okay. Now, both of them have a specific set of differentiating characters which I have put up in this table. First is timing at which they present with conjunctivitis. Gonococci is something which occurs early. It usually occurs between day 3 to day 7, or you can remember in the first week of treatment. Whereas chlamydia trachomatis has a little late presentation from day 5 onwards. Okay? Or you can remember like this, from second week. Even though it's not strictly second week, you can just remember as second week onwards. Okay. Next is regarding the presence of discharge and how much it is present. Definitely lot of discharge is present in case of gonococci infection. It is a copious and purulent discharge. Whereas for chlamydia, it is very, very scarce or scanty discharge only is present in chlamydia conjunctivitis. Regarding the treatment of conjunctivitis, first about gonococcal conjunctivitis. Even though this is only a conjunctival infection, it can spread very rapidly. Thereby, there is a risk of blindness in the newborn. Next thing, it can also cause a systemic infection. So that is why gonococcal conjunctivitis is regarded as an emergency and treatment has to be started with parenteral antibiotics. Okay, and what is the usual antibiotic which we give? It is intravenous third generation cephalosporin like ceftriaxone, which is given for a period of 7 to 10 days. Another third generation cephalosporin cefotaxime, which can also be used for the same duration. For chlamydia, what is the antibiotic of choice? It is oral macrolides. So examples of oral macrolide would include azithromycin or erythromycin. If you are using azithromycin, the typical course is for 3 days. And if you are using erythromycin, it is generally given for a period of 14 days. This is how you differentiate and treat gonococcal and chlamydial conjunctivitis. The general term which we use for conjunctivitis in a newborn baby is ophthalmia neonatorum. Okay, ophthalmia neonatorum. And there's a very common question which can be asked in the exam. If you want to prevent ophthalmia neonatorum, what should be applied on the eye of a newborn? It's a very common question. Or in other words, they can ask you like prophylaxis of ophthalmia neonatorum. It is application of topical erythromycin eye ointment, which is 0.5% erythromycin eye ointment is required. Topical application of 0.5% erythromycin ointment is the prophylaxis of choice against ophthalmia neonatorum. Okay, so I have discussed in this superficial infections about conjunctivitis, oral thrush as well as omphalitis. Now let's move on to the discussion of systemic infections in the newborn. I've already said that systemic infections in the newborn goes by the name of sepsis. Remember, sepsis is an important condition because it is the second most common cause of neonatal mortality. Well then, what is the most common cause? The first or the most common cause would be prematurity. The most common overall cause of neonatal mortality is prematurity. Second is neonatal sepsis. This by itself is an important MCQ question. Okay, right. So what is sepsis? Sepsis is actually a clinical syndrome which is characterized by signs and symptoms of infection, usually associated with bacteremia in the first month of life. Very simple. You should have clinical features of sepsis. Along with that, there is usually bacteremia. What is the meaning of bacteremia? It is the presence of bacteria in the blood as detected by blood culture. This is what you call it as sepsis. If it occurs in the first month of life, you call it neonatal sepsis. Generally, when we talk about infections or sepsis, you should know about what is the organism which is causing the infection. Generally, remember, it is caused by bacteria. Okay. Now, the spectrum of organism causing the infections is slightly different in India when compared to the rest of the world. Okay. So, for your exams, you should know about first, what is the common organism in the Indian scenario, and the other one is worldwide scenario. In India, the commonest organism, number one organism is Klebsiella. Number one is Klebsiella. Number two, Staphylococcus aureus. And number three is E. coli. These are three important organisms which causes sepsis in order of frequency in India. Most common overall is Klebsiella. Okay. Now, if the same question is asked about worldwide, what is the commonest organism? Then your answer is something called as GBS. What is GBS? It is group B streptococci. Okay, group B streptococci. That is the overall most common cause worldwide, whereas in India, it's always Klebsiella. Okay, now talking about neonatal sepsis, we divide it into two categories called early onset and late onset, depending on the onset of the infection. Okay, if the infection occurs in the first 72 hours after birth, it is called as early onset. So early is first 72 hours. Late is obviously after 72 hours after birth. Why this distinction is because it helps us to differentiate from where the baby would have acquired the infection. For example, if it is in the first 72 hours or early onset, it is definitely from the maternal source. It could be either in the maternal uterine environment, or it could be while passing through the infected birth canal of the mother. That is where baby should have acquired the infection in early onset sepsis. Whereas if it is late onset sepsis, obviously it is not maternal source, it is something which is outside. What is that? In the first few days, where is the baby? The baby is in the hospital environment from where it should have acquired it. Okay, so late onset sepsis is hospital acquired infection, or what we also call it as a nosocomial infection. Okay, so the source will vary depending on the onset of sepsis. There are some risk factors for acquiring the infection. In early onset infection, I told you it is maternal factors. So it's something related to maternal infection. For example, a very important infection which should come to our mind is chorioamnionitis, which is characterized by high fever in the mother along with a foul smelling liquor. Next important is duration of ROM. What is that? Rupture of membrane. If it is more than 24 hours, okay, is considered as a risk factors. And at this point, you should remember, if it is more than 72 hours, it is even more risk, or I will write it as a very high risk. Okay, high risk. Okay. The next thing is PPROM. What is that? It is preterm premature rupture of membrane of any duration is significant. Okay. And one more important is number of vaginal examinations in the labor. Okay. Especially we are talking about unclean vaginal examinations during labor, especially if it is more than or equal to 3 unclean vaginal examination. That again is a risk factor for development of early onset sepsis. As you can see, all of them are almost exclusively maternal risk factors for early onset sepsis. What about late onset sepsis? The most important risk factor is not maintaining aseptic precautions in the hospital environment, especially the unclean hands of the health personnel. Unclean hands of the health personnel is the most important contributing risk factor, and this has been even asked as an exam question. They asked like this: which of the following is the most important preventive measure in late onset sepsis? It is maintaining strict hygiene, especially maintaining strict hand hygiene. That's a way of preventing late onset infection. Okay. The other risk factors would include a baby being born as a preterm baby or born as a low birth weight baby. Even absence of breastfeeding is considered as a risk factor. We all know that breastfeeding contains lot of competent factors and immunocompetent cells like antibodies, okay, which will help in combating infection. So absence of breastfeeding by itself is a risk factor for late onset sepsis. Okay. Last point to be remembered, what is the type of infection? Okay, right. In early onset sepsis, generally presentation is with pneumonia, whereas in late onset sepsis, the typical presentation includes bloodstream infection, or what we call it as septicemia. It can also present with even more dangerous type of infection, that is meningitis. These are the typical types of infection in different types of sepsis. So this helps us to differentiate between the two categories of sepsis, namely early onset and late onset sepsis. Coming to how to diagnose a child is actually having a sepsis or clinical features of sepsis. Let me tell you one very, very important thing. There is no clinical feature which will pinpoint you to the diagnosis of sepsis. That is why when you enter into the ICUs, where you see all the sick newborn babies, every baby would be receiving an antibiotic, which you can actually see in that order sheet of that particular baby. Why? Because no clinical feature helps you to pinpoint the diagnosis of sepsis, and it is a rule in NICU that any sick baby is considered to have sepsis and you have to start treatment. Why it is even more important? Because if you don't suspect sepsis, and in fact if it was a sepsis, it can even cause death in the baby, because I told you neonatal sepsis is the second most common cause of neonatal mortality. So that is why, remember, any sick baby, you suspect sepsis and you straight away start antibiotic treatment. That is the rule in the NICUs. Okay. However, for your exams, you should also know some important manifestations of sepsis which may be asked for your exams. Okay. One of the early features of sepsis is altered feeding pattern. Altered feeding pattern. The mother will tell you like this: the baby was previously feeding every 2 hours perfectly, but I am now seeing for the past few hours, baby is not feeding like every 2 hours. Baby is not even interested to feed. And the mother can tell you the baby is not active or lethargic baby. These are common early presenting features of sepsis. Okay. Next important thing is, what is a reliable feature if at all present? Remember, most of the infections we are expecting fever as a feature. However, in a newborn baby, fever will not occur. Instead, it is hypothermia. Okay. Right? It is low temperatures which could be a feature. And in fact, it is hypothermia which is more common compared to fever in a preterm baby, and that is why we give lot of importance to this presenting feature. Okay. The other features depend upon the focus of infection. For example, if it is a pneumonia, the baby can present with respiratory distress or breathing difficulty. In case of meningitis, you could get seizures. So all these are presenting features of neonatal sepsis. However, remember, there is no one feature which is diagnostic of sepsis. So again, the dictum: suspect sepsis in any sick baby and start treatment. Okay. Now, going to the management of neonatal sepsis. If you cannot diagnose a condition by clinical features, what are you going to rely on? Definitely we are going to rely on investigation. And if I ask you which is the best investigation for diagnosis of sepsis, obviously being an infection, and that too bacterial infection, what should be the investigation of choice? It is nothing but blood culture. Blood culture is the gold standard method of diagnosing neonatal sepsis. The only issue with the blood culture is, if you send the blood culture reports today, you will require at least 72 hours, 48 to 72 hours at least, to get an initial report of what is the organism growing in the culture. Okay. So it will take time. So again, we will not wait for the blood culture report. Instead, we will start empirical antibiotics. Okay. That's the rule for neonatal sepsis. Okay. We can also do something called as a screening investigation, which we call it as sepsis screening, which basically includes our basic test like blood counts, ESR, like that. And we have got 5 parameters related to this, which are the components of sepsis screen: total leukocyte count, absolute neutrophil count, immature to total neutrophil ratio, micro ESR, and CRP. First is regarding the total leukocyte or the WBC count. Generally, in an infection, we are expecting an increase in the WBC count, right? However, in a newborn baby with sepsis, there is actually decrease in the WBC count to less than 5,000 WBCs per cubic millimeter. Okay, why it is happening like that? It is because of immaturity of the immune system of the baby, wherein it cannot mount a response to infection. That is why the WBC count is decreasing. Even the neutrophil count also will be decreased to less than 1,800 cells per cubic millimeter. Okay, right. And in the condition of sepsis, there is an increase in immature neutrophils in the circulation. So if you keep a ratio between immature and total neutrophil ratio, the ratio will become increased. In the sense, there is increased amount of immature neutrophils in the circulation. How it is defined? It is defined as more than 20% of the neutrophils are immature neutrophils, then it is significant. We can also express it in an absolute number as more than 0.2. Okay, so if the ratio is more than 20% or more than 0.2, it is significant. ESR, we measure it as micro ESR in the newborn sepsis screen. If the value is more than or equal to 15 millimeter in 1 hour, it is considered as significant. Last is an inflammatory marker called C-reactive protein. If the values are more than or equal to 1 milligram per deciliter, then also it is considered as significant. So I have told you 5 parameters in the sepsis screen. If any two are present, then it is considered as significant. Okay? Now, understand the role of sepsis screen. It is not for diagnosis of infection. The value of sepsis screen is to rule out an infection, or in other words, it has got a negative predictive value. What is the meaning of negative predictive value? If the test is negative, it means infection is unlikely. However, if the test is positive, still we cannot diagnose sepsis. We always have to go for the diagnostic investigation, and that is blood culture. So remember, the value of sepsis screen is only as a negative predictive value to rule out an infection rather than ruling in an infection. Okay, this is something which you should know about. Now, talking about C-reactive protein, remember this C-reactive protein rises 6 to 12 hours after infection, and peak of that C-reactive protein is after 24 hours, which is slightly considered as a drawback. Why? Because in the early stage of infection, it is negative. Okay, so that is why we have started looking for new inflammatory markers in systemic infection or neonatal sepsis, and that new marker is procalcitonin. Now, this procalcitonin is a better marker than CRP because it rises early in infection. It rises by 4 to 6 hours after infection and attains a peak by 24 hours itself. Whereas CRP is rising only after 6 hours and peaking after 24 hours. So that is why procalcitonin is a better marker and has a better sensitivity in sepsis screening compared to C-reactive protein. Okay, but please remember, procalcitonin is not routinely included in the sepsis screen of all the hospitals or all clinical settings. It is only CRP which is still commonly used. However, you should be aware of the marker procalcitonin. That is why I have included in my discussion. Okay, other than this blood culture and screening, what other investigation can help? Okay, depending on the situation, you can arrange an investigation. For example, if you have a baby whose main presenting feature is respiratory distress and you are suspecting pneumonia as an infection, you can order a chest X-ray. Okay, right. And one more important investigation which you are supposed to do to rule out meningitis is lumbar puncture. Okay, to rule out meningitis is lumbar puncture. At present, what is the role of lumbar puncture? It is indicated in all babies with suspected or confirmed sepsis, except in asymptomatic babies. Okay. What is the group of this asymptomatic babies? That means baby is otherwise fine, but there were risk factors in the baby. So that's why you are starting antibiotics, or that's why you started infection. Then they are called asymptomatic babies. That babies alone, lumbar puncture is not indicated. However, if the baby shows any of the signs of sepsis, then definitely you have to do lumbar puncture, and that is what is the present guideline. So these are all the different investigations. The main purpose of doing lumbar puncture is to collect the CSF for analysis and to send the CSF for culture. So these are the main investigation which I'm supposed to do in a baby with sepsis. Now moving on to treatment of neonatal sepsis. Obviously, it is antibiotics, and as I told you, any sick baby, you start antibiotics empirically. Okay, what is the principle of this empirical antibiotic? It has to cover a wide spectrum of bacteria. Okay, so it has to cover both a gram-positive spectrum as well as gram-negative spectrum. For gram-positive spectrum, the usual antibiotic which is started is ampicillin, which is a penicillin. And for gram-negative spectrum, I will start with an aminoglycoside like amikacin or gentamicin. Anyone I can choose. So usual initial combination is ampicillin plus amikacin, which is a combination of penicillin and aminoglycoside. Okay. Now, after starting antibiotics, if there is no response by 48 hours, or the baby is suspected to have a severe form of infection, like for example meningitis, or the baby is presenting with septic shock. In this situation, I have to add a third generation cephalosporin. A typical example of a third generation cephalosporin would be like a ceftriaxone or cefotaxime. Okay. So what is the indication for starting a third generation cephalosporin? It is no response to initial antibiotic by 48 hours, or a severe infection like meningitis is suspected, or if the baby presents in septic shock. Okay. One more important aspect of management is if you are suspecting a Staph aureus infection, like for example in that ICU setup, there are high incidence of Staph aureus infection. You have to add cloxacillin. Okay. And in that same ICU, if there is high incidence of MRSA, that is methicillin resistant Staph aureus, instead of cloxacillin, you will add vancomycin to the antibiotic regime. Okay. These are the usual principles of antibiotic treatment in neonatal sepsis. You can have one more peculiar scenario where you are treating the baby in the ICU which has got a high incidence of resistant strain. In that case, you are supposed to start directly with the third generation cephalosporin like cefotaxime or piptas, that is piperazolin tazobactam, or ciprofloxacin. In addition, you have to add an aminoglycoside like amikacin. Okay, right. This is what is recommended whenever there is ICU is reporting a very high incidence of resistant strains. So these are the different antibiotic treatment regimes in neonatal sepsis. The next question to be remembered is how long you are going to continue antibiotic treatment in sepsis. It depends on few things. It depends on whether the culture is positive or negative, and number two, the type of infection. For example, if it is a culture negative sepsis, what is the meaning? You started antibiotics because the baby was having some clinical course consistent with the sepsis, or baby had risk factors, but the culture turned out to be negative. That is called as culture negative sepsis. Here, the usual duration of antibiotics is 5 to 7 days. Okay. Suppose blood culture is positive, but there is no meningitis, then you have to treat for 14 days. Okay. If it is meningitis, that means CSF culture is positive, then treatment has to be given for 3 weeks. Okay, and fourth is a peculiar scenario called ventriculitis, which is usually diagnosed by MRI imaging showing some inflammation in the ventricles. Then treatment has to be continued for an even longer duration of 4 to 6 weeks. So these are the different treatment duration depending on the course of neonatal sepsis. Okay, so with that we complete the discussion of infections in the neonate.